progress on our total cost of care efforts here at Corp. Before I start, I just want to give an extra thanks to Katie Dobler for being here today and helping us with this presentation, and also our cost of care steering committee, who's been guiding this work for about 2 years. I know a number of them are on the phone right now, so please join me in thanking them for their efforts. We would not be where we are today without them. So I'm going to go through a little bit about Corp. I know many of you know Corp, so this will be brief. But we are a independent nonprofit here based in Portland, but covering the entire state. Our mission is to improve the quality and affordability of healthcare for all Oregonians. And we're proud to just have celebrated our 15th anniversary back last fall, and we're still going strong. One of the things we pride ourselves on is bringing all stakeholders to the table to solve the most pressing healthcare issues for our state. So as you see on the slide, these are some of the stakeholder groups that we work with on a variety of topics, and we really believe that the best solutions can be found when everyone is at the table listening to each other. Just briefly, let me tell you about how we do our work. First, we spend a lot of time thinking about how best to bring the community together to solve quality and cost issues. So that could be a region of the state, it could be the entire state, or it could be bringing Oregon's perspective to the nationwide perspective. We also do a lot of reporting of quality and utilization information. And using this data, we can actually also produce some pretty sophisticated analytics. Right now, we're operating one of the most validated claims databases in Oregon. And this allows us to report to a variety of audiences, including providers, health plans, and the public. But we also do custom reporting for members of the community who want to understand an issue that they might be grappling with and contract with us to help them find solutions. To give you a better idea of what is included in our database, in 2016, our database includes 80% of fully insured commercial population. For the self-insured commercial population, that is reduced to about 35%. We have 100% of the Medicaid population in our database, and then about 92% of Medicare. That includes Medicare Advantage as well as Medicare fee-for-service, because CMS has designated us a qualified entity, which means we can have access to Medicare fee-for-service data. I also wanted to mention that we are not in this alone. There are between 35 and 40 organizations like Corp around the country. And we are organized in the Network for Regional Healthcare Improvement, otherwise known as ENRI. And we work to make sure that we advance the best ideas around the country. We work together on projects, and we really focus on spreading the great deeds that are being done at individual community levels. Leah Christensen, who many of you know, is Corp's executive director, but she's also the chair of the board of ENRI. So we have a loud voice at the national table. I want to talk to you a little bit about the Total Cost of Care project. And like I said, we're very tied in with these 40 regions around the country. And one of the benefits of that is we can work on multi-region projects. So the Total Cost of Care project is one of those. This is a project that the Robert Wood Johnson Foundation started funding about 2.5 years ago. We started with 5 regions around the country, so Colorado, Maine, St. Louis, Minnesota, and Oregon. And we took these total cost of care measures that we'll be talking about today and tried to standardize them across the regions and experimented with different methods of reporting within the regions. It was a very successful project. We've expanded to 2 other regions now, Utah and Maryland. And we also have 4 regions that would like to report this information, but aren't quite ready to. So we call these our development regions. The point of this is it started with a small community, and now it's spreading across the country, and we anticipate more and more growth as time goes on. I'm going to turn it over to Doug now to talk about the total cost of care measures and a little bit about the methodology that goes into producing them. Doug?
Great, thanks, Meredith. I do want to go do a quick overview of the cost of care measures and how we decided to use the particular measures that we're using, as well as what goes into the measures and a little bit about their background. And then I wanted to spend a few minutes also digging a little bit more deeply into the measures and the actual math that's used in order to calculate them. First of all, the measures we're using to show costs were developed by Health Partners, which is an integrated health system based in Minnesota. And they had developed two different measures. And the slide before you shows how the two measures fit together. There's a total cost component and then a resource use component. And those are the two measures that, that Health Partners developed. The total cost component gives the overall cost effectiveness of managing a panel of patients. And it includes all of the costs for all of the patients attributed to a panel for a one-year period. And the total cost includes both utilization and price. The other measure that Health Partners developed is the resource use component. And this component isolates the utilization and uses standardized pricing to do so. And it measures the frequency and intensity of the services used. So these measures were designed to highlight the cost savings opportunities and identify potential instances of overuse or inefficiency within a system. Then the other component that's shown on this slide is price. And by simply dividing the total cost by the resource use, so pulling out that resource use or utilization component, we can get to the price component. And the price component is affected by the actual prices that are paid for services. And those can be affected by the fee schedules or referral patterns or where the services are rendered. One of the reasons that the project team selected the Health Partners measures is because of their NQF endorsement. Health Partners had the measures and took the measures to the NQF, and in January of 2012, after the rigorous review process that NQF does on the measures, they determined that they were reliable and valid measures and the NQF gave the measures the endorsement. So these are just from the NQF website for the two measures, the total cost index and the resource use index. And of note is that this is the first time the NQF has endorsed a total cost, full population cost of care measure. So a little bit more about this particular methodology. The Health Partners total cost of care methodology uses claims data and to calculate population-based measures for the cost of health care for an attributed population. And these costs include the professional services, outpatient services, inpatient services, and pharmacy. And they are the costs that are paid by both the patient and the insurer. So the idea is that this is the what it costs the system to provide the care on the average for a panel of patients. The methodology has been endorsed and we are using only for the commercially insured population. So this does exclude both Medicare and Medicaid. If any of you know about those reimbursements, they're so very different that it's hard to compare between those three populations on cost. We are working on another project that we'll be happy to let you know more about if you're interested in on applying these measures to the Medicare population. And we eventually would like to apply them to the Medicaid population. We've had a lot of requests to do so. So the way that the Q-Corp is reporting the measures is at the clinic level, and it's compared against a benchmark, which we're using a statewide benchmark that includes all of the clinics that we're reporting on. And I just wanted to mention also the Health Partners methodology has been in use for over 11 years now, and I think when we started there were under 70 licenses in being used, but now there are 125 licenses, and they're across 35 states. So this is a fairly widely adopted measure at this point. The other component of determining these costs is risk adjustment. So Health Partners has a couple of ways to sort of level the playing field and sort of equalize out the differences in panel populations, differences in illness burden, age, and gender. So what Health Partners has used for the endorsement and the methodology that we used is the Johns Hopkins Adjusted Clinical Groupers, ACGs, which is a risk adjustment system that groups patients based on their gender, age, and diagnosis, and then weights the patients based on how severe those or how high an illness burden you would expect based on those. So this is based on each individual, and it captures all of the diagnoses for the entire measurement period of 1 year. In addition, Health Partners is sort of leveling the playing field by capping the costs at $100,000 per patient, and then only including age 1 to 65. So eliminating the babies, which can have very different costs, and people over 65, as this is a commercial population. So I wanted to go into a little bit more about the numbers behind the two measures. The first measure is the total cost index, and this is calculated by calculating per member per month costs, a total per PM cost, per member per month cost, which is taking the total medical costs for a patient and dividing it by the number of months that they were that they had coverage, that they were insured, and adding the pharmacy costs and dividing by the number of months that they were insured. So this is done for the whole panel of patients. So we're getting an average cost per month per patient for the patients that are attributed to the clinic. And then that's divided by the risk score, that risk adjuster score, which takes into account the expected illness burden, which gives us a risk-adjusted per member per month cost. And then that risk-adjusted cost, we can compare that to the state average and get a number that's close to 1, the state average being 1. And so any clinic that has a score over 1 would have higher than average, higher than expected costs. And any clinic that has costs less than 1 would have lower than expected costs. The second measure uses a standard cost methodology. So instead of using those actual costs that are paid by the insurance company and the patient, for any particular service, the same cost is used. So this really does factor out the price component. And the scale for these standardized costs that Health Partners uses is called the total cost relative resource use value. So each service in the healthcare that can be reimbursed for healthcare has a particular value, and it's based on the effort, the amount of resources that go into providing that particular service. And for those of you that are familiar with other types of of weighting systems such as what CMS has. There's a little more detail on where Health Partners derives these values. And they've done made an effort to allow the costs to be compared across inpatient, outpatient, professional, and pharmacy, so that it makes sense if an MRI is done one place or another. The relative resource value, they're attempting to make sure that those stay constant no matter where the service is provided. So the total TCRRV would just be the number of service units times this weight to get you the standardized cost. And so the calculation for the resource use index is very similar to the calculation for the total cost index, except that it substitutes those TCRRVs, those standardized costs, instead of the actual costs. So now I'd like to review the report package that we sent out. We've sent a second round of reporting packages, or a second round of clinic-level reports this year, and as a follow-up to the reports that we sent out a year ago, April. This year we sent out reports to 79 different medical groups across the state, and we sent 143 reports on the adult population and 44 reports on the pediatric population. And again, these are at the clinic level, but the reports were sent to the medical group contact for the Corp provider portal. So they were sent at to both by email and by post to the medical group contact. The reports we developed last year with our cost of care steering committee, and this year that committee decided that they wanted to keep the reports pretty much the same, just so that as people become familiar with it, we're not making a lot of changes. So the report layout, the contents of the report is similar to what it was a year ago. There's a 2-page cover letter, and then a 2-page definition and glossary sheet. And then the bulk of the report, which this year is 9 pages. But there's there's an overview of the clinic, cost, and demographics. And then there are drill downs to various levels that are shown here: professional, outpatient, imaging, ER, inpatient, chronic conditions, and pharmacy. And finally, this year we added a new page, which is the year-over-year trends, which we were able to do now because we have an additional year of data. Accompanying the report, we have an FAQ sheet, which I think is now 9 pages, and folks have found that really helpful in understanding the report. So I wanted to drill down. Let me just go over a little bit of more information about the reports. As I mentioned, we sent adult and pediatric reports. We split out the populations because they are fairly different, and we've heard in other regions that it's helpful to look at the two populations differently. And when we've looked at the top pharmaceuticals and just inpatient costs and types of services, they really are very different populations. So that's been well received to break those out into 2 different sections. For the reports, there are a minimum of 600 commercial patients that are in our database. And this is the number that Health Partners use to get the NQF endorsement. They are recommending different numbers of attributed patients for different purposes, some higher, some lower, based on the purpose. But in order to look at a clinic population in this way, they're recommending that 600 threshold. Again, the cost measures are limited to patients between 1 and 64, and the costs are capped at $100,000. So as far as the data goes, Corp is calculating the total cost of care measures on about 33% of the total commercial population. We do have a requirement that's part of the methodology that patients are enrolled for 9 months in the data, as well as these age restrictions and other restrictions bring down the total number of patients that we're able to report on. QCOR is using 7 of our data suppliers that have given us the ability to report on cost. We're working with our other data suppliers as well as data suppliers we're not contracted with right now to increase that number and hopefully have a broader picture of the clinic overall population. I wanted to show a little bit of the actual report. I've got 2 slides here. The first one shows some overall characteristics about the clinic from the cost perspective, and the second slide shows a more drill down version of the cost. So on this first slide, there's in the upper left-hand corner, there's a chart called Overall Summary by Service Category. And this is really the meat of the cost portion of the clinic reports. So if you look at the overall line, down there at the bottom line, there's a raw PMPM of $417.03. And this is the average cost for this particular clinic's patients per month, with those few caveats of restricting to, in this case, adults, so 18 to 64, capping the cost at $100,000. And then the next column shows the adjusted PMPM. So this is the risk-adjusted per member per month cost. And in this case, it's quite a bit lower. If you look over at the right side of the right box, of the upper right box, there's the clinic risk score. And in this case, the clinic risk score is 1.11 versus the Oregon average of 1.0. And so this clinic has a higher illness burden than the state as an average. And so their adjusted PMPM costs are brought down by that amount. This is actually dividing 417 by the 1.11 in order to get the 376. And that, in this case, sort of compensates the costs for this clinic because they have a higher illness burden at this clinic. So when we compare the adjusted cost to the Oregon average, which is the next column of $424, we get the TCI of 0.89. TCI of 0.89 means that this clinic's overall costs for managing the care of their patients is about 89% of what we would expect based on the state as a whole. So they're a little bit cheaper, about 11% cheaper, lower cost overall to manage their patients. And then again, we've got the next 2 columns. The resource use, the other health partners measure, in this case is 0.85, and that's based on using those standardized costs versus the Oregon average. And finally, there's the price component, which in this case is 1.05, showing that as far as price goes, this clinic patients are to cover the care of these patients, it's a little bit higher than average in the state overall on the price. Then the chart on the lower portion of this slide shows a scatter plot with all of the clinics in Oregon and this particular clinic highlighted in blue. And it shows the resource use and the price index numbers from the chart above and where the clinic falls. This clinic falls in the upper left quadrant, showing that they have higher price and lower use than the state as a whole. The average in the state would be in the crosshairs of where the 4 quadrants all come together. I wanted to point out one other thing on this sheet. Under the price index, there are two boxes that are shaded in blue. And anywhere on the report that TCI, RUI, or price are shaded in blue means that those costs are 10% or more above the Oregon average. And we heard from our cost of care steering committee that they'd like to see some way of highlighting places where clinics should look. And so this was the way that we decided to go about doing that. On the next slide is a drill down into more one of the more details, in this case, the inpatient sheet. On the upper left is the same grid that we saw in the last sheet, the overall summary by service category. And then the other two charts come from the inpatient page. The top chart showing the costs, as well as the total cost index, the resource use, and the price index for the breakout of inpatient costs. And the lower chart showing a similar scatter plot, but this time only showing the inpatient price versus resource use. So on the next slide, we have wanted to show some of the other ways we're looking at variation overall across the state. This chart shows that total cost index, put in order all the clinics that we are reporting on and how they fall on the chart. And you can see that there is a tail at the top and the tail at the bottom. So the lower left clinics are performing at a lower total cost for their patients, and the upper right is those are higher costs than average. For those of you that would be interested, I've also shown the standard deviation lines. In this case, it's 1.09, 1.1. I'm sorry, 0.11 is the standard deviation on this chart. The next chart shows another way of looking at the total cost on a scatter plot. In this case, we're looking at that total cost index compared to the quality index. And in this case, we've divided the clinics by what part of the state they're located in. And as you look across here, you can see that there is a lot of variation. And we've got a lot of dots in all four quadrants. There isn't particularly a line that appears here. So there isn't really a strong correlation between cost as represented by the total cost index and quality as represented by a quality composite that we developed based on Corp quality measures. And also, when you look at the regions, although some regions tend to be higher cost and some regions tend to be lower cost, there's a lot of variation within each region also, both on the cost side and on the quality side. So that's the basic that I wanted to show you to explain about the measures. If you have any other questions, please feel free to contact us. If this is new information, it's not easy information. So please contact us, and either Meredith or I will be more than happy to spend some time with you. But next, we'd like to hear from Katie Dobler, who would like to share her experiences with the clinic level reports. Katie is the Chief Operating Officer. She's just recently changed positions at the Portland Clinic, and she's also the Executive Director of the Portland Coordinated Care Association. So Katie?
Thanks, Doug. So the Portland Clinic is part of an organization called the Portland Coordinated Care Association, and it's made up of independent groups around the Portland area. And we came together a little bit over 3 years ago and really started focusing on best practices, referral guidelines, at that time really to meet the triple aim. And we now have a handful of insurance contracts as well. But we've done a lot of work around again, metrics, and sharing information very candidly with all of our groups, and those include many people on the phone: Northwest Primary Care, Westside Internal Medicine, South Tabor, and the Portland Clinic are the adult primary care groups in the Portland Coordinated Care Association. So we were very excited when we saw these reports, and we felt that we could really do something with them. So we met with Meredith and Doug several times, and the groups all signed a waiver to allow us to combine our data. So Doug worked hard on that, and yeah, next slide's fine. And basically what they did was they plotted PCCA on this graph, as Doug was showing earlier, so we could see as a group how we were doing. Now this is 2013 data, and we really started really doing committee meetings, et cetera, at this time. So we see this as our baseline, and we're excited for more reports to come out. We're working on combining our data for this current report that just came out, and we plan to do kind of side-by-side comparisons, if you will, as we continue to get more data. So again, we see this as our baseline, and we only hope to improve from here. Internally, we have a website, and again, this is based on just the first report that came out last year. We decided to pick some measures. So this slide here is the rate per 100 potentially avoidable ED visits, and the groups are represented here on the slide, the black line being the Oregon average. So again, while we're below that, we really hope that the work we're doing together will even help us to improve these measures. And so we'll be stacking them up side by side as we work on this year's report and future reports with Quality Core. So we found this very helpful on a variety of fronts. Obviously, again, looking at the work we're doing and how it's affecting these measures. And also, as we're talking now more with insurance companies to do contracting to really prove that we are what we say we are as an organization. I want to make sure we leave time for a question, so we'll hand it over to Meredith.
Thank you, Katie. I'm just going to briefly, this is Meredith again, I'm going to briefly go over our next steps and where we are in our cost of care journey. So we started this work almost 3 years ago. It's hard to believe. From the very beginning, just like all of Q-Core's new measures, we said we would spend a lot of time testing these measures. So one of the first things that we committed to was sending these reports out twice privately to primary care clinics to make sure that they understand what the reports are reflecting and help them get used to what these measures are actually reflecting, and give them a chance to ask questions. So as Doug mentioned, we recently sent out our second round of reports, so that phase is done. We also report on a statewide level. So last summer we produced a statewide report that showed a lot of different slices and dices at a more regional level of what can be shown with this data, and also what can be shown by, if we as a state agree to try to reduce the total cost of care by 1 or 2%, what that could mean for the rest of the services that we need in the state, like bridges and schools, et cetera. The third phase is making this information more widely available, and specifically we're looking at health plans and policymakers. So later this summer, we have agreed to provide this data to the 7 health plans who are allowing us to use this information. They took a risk on us that we'd be able to produce these measures and these reports, and now we owe them a sense of how the clinics are doing. So what we hope throughout this process is the health plans will use this information for their quality improvement efforts and to increase transparency about what's going on in the state. We are asking that while the measure is still being tested, the plans not use this data for contracting purposes, but really to try to make improvements at the plan and state level. The fourth phase that we've talked about since we began this process is how to report to consumers. And if you're familiar with Q-Core, you know that we have a robust public-facing website. And we've been transparent from the beginning that as we're testing this measure, the ultimate goal will be to get this information into consumers' hands. So obviously the information has to be in an appropriate level, and we'll work with our cost of care steering committee to make sure the information is useful for consumers. I can guarantee you that the report will not look like the report that some of you received last month. It'll be much more summarized and to help point consumers in the right direction. I will say also that one of the things that we've committed to as we started reporting on cost is that we'll never report cost without quality. The last thing we want to do is send patients or have the community believe that a low-cost provider is definitely the way to go. If they were lower quality as well, that information needs to be transparent. So we will never report costs without a pairing quality measure. Some of our next steps, as Doug mentioned, we've heard loud and clear that clinics are very interested in seeing similar information for the Medicaid and Medicare populations. So along with our national organization, we are working to pilot these as possibilities. So recently we were awarded a contract. We are one of 3 regions to pilot total cost of care at the Medicare fee-for-service population. So that work will start very shortly and will be done sometime this fall. So we can really understand how it is appropriate to report on the Medicare population. Again, this is really new territory, so we think it's important to pilot this before sending it out in a more transparent way. We're also looking hard at year-over-year variations, and as Doug said, we included a new page in this round of reports, but we want to look at it more at a regional and state level and try to understand what might be causing variation from year to year. We're in our second phase of grants from the Robert Wood Johnson Foundation. The Phase 3 grant proposal is under review as we speak, so this would allow for additional reporting through 2017. We'll also be able to explore Medicaid a little bit more, and we'll continue being able to mentor those additional communities. As I mentioned at the beginning, this project is spreading, and as one of the first 5 regions in the country who have been reporting these measures, we're considered pioneers, and we're really looking forward to going out and teaching communities the lessons that we learned and helping them avoid the same mistakes that we made. We're also looking at different ways that this information can be sliced and diced. So as Katie said, PCCA has contracted with us to look at the measures on a multi-clinic view. We've had other organizations approach us with similar requests, but we know this information can be used for multiple purposes. So we're always on the lookout for good ideas. The last thing I want to mention is one of the major questions we got last year after we introduced these reports is, okay, now we have this information, what are we supposed to do with it? So to respond to that concern, we put together a technical assistance work group that was part of the cost of care steering committee. And through a series of 5 or 6 meetings, that work helped us prioritize what we could do to help clinics interpret and use this information. So the list you have in front of you here is a list a prioritized list that the group helped us come up with. Some are heavy lists, some are light lists, some are things we can do within our current budget, some would require additional funding. But we want to make it clear that we are listening to what the clinics need, and we're really looking forward to providing some high-value products to help clinics along in interpreting and making the most out of this data. So I will stop there. Here's a reminder of how to ask questions. And I'll turn it over to Megan to see what we've heard.
All right, great. We do have a few questions. So again, just please send them into the questions pane, and I will ask them of those in the room, and they can answer them. So our first question is, what types of clinics are being measured and reported on for these reports?
Sure. I'll start, and Doug can correct me if I'm incorrect. These are clinics that we currently have legal agreements with. So to receive Q-Core reports in general, clinics sign 2 agreements, a portal access agreement and a business associates agreement that let us report back to the clinic. So that's requirement number 1. The other requirement is the clinics need to have at least 600 attributed commercial patients. So for clinics that see a lot of Medicare patients or a lot of Medicaid patients, or they happen to see a lot of patients from health plans that don't currently allow us to use the cost information, that clinic might not be in this group of 180 reports that recently went out. So those are the primary considerations in determining whether a clinic gets a report.
I would just add that that these are also going to primary care clinics. So we attribute to primary care doctors. So anyone who does not see a primary care doc would not be included, and any specialist groups would not be getting reports.
I have something as well. This is Katie. They're brick and mortar clinics. So the Fulton Clinic has several clinics, and we may not get one if we have one smaller location for one of our clinics. So that, I remember that was confusing in the beginning as well.
Yeah. So each doorbell
yes.
has to have 600 attributed patients. Thanks for the clarification.
Great. So our next question is on the QCI versus QI chart that you showed about whether that would be possible for this person to see their clinic on that chart and then learn what other clinics are in their region.
On the quality chart, yeah. We are looking at how we'll be revising the clinic level reports, and we would like to incorporate in more of a cost component like this. So at this time we don't have that available to clinics, but we will be making, we do have that definitely on our radar. And if this question is being asked by someone who is not involved in our cost of care steering committee, then we would encourage you to, to let us know. Otherwise, our cost of care steering committee will be guiding a lot of the work that we'll be doing in the future.
I would be remiss not to mention too that we have gotten one-off requests from clinics who are looking for this sort of information, and although it's not something we have funding to produce a mass production at this point, if there is a need at a clinic level, let us know, and we can contract separately.
So a follow-up to that is it possible to receive a roll-up report showing performance across all clinic locations in addition to individual clinic reports?
I mean, we did that with the Portland Coordinated Care Association, and you could do it for your own medical group as well, I think.
Absolutely. And, there are some rather large medical groups out there, and I can imagine that they would want to see a rolled up amount and perhaps how the clinics compare to each other. So that is definitely a possibility, and we'd be happy to discuss further.
There's another question about accessing the reports online and how do you register for that. So I'll take the first stab at this question, which is actually that these reports are not currently available online. They're only being sent out through email as PDFs and as hard copies. We are working on updating our systems in hopes that we can at some point make these reports available online. Our quality reports are, however, available online through a secure portal, and you can get access to that secure portal through the medical group contacts. They can provide access to other people within the medical group, so if you do not already have access to the portal, you can email me directly or somebody else at QCOR, and we can tell you who that person is, and you can go reach out to them, and they can provide you with access to the quality reporting portal online.
The other thing I'll say, these reports were a labor of love, and there's absolutely nothing automated about these reports. Doug has had hundreds of iterations and designs of these reports, and he single-handedly, honestly, has created all the reports. I can help PDF and I can stuff envelopes, but this is a very, very manual process. We certainly would love that to become less manual. We just haven't had the funding to explore different options, but we are looking forward to that down the road.
And then the last question that we have right now is just, will the slide deck be sent out? And yes, it will be sent out. We're also recording today's webinar. I forgot to mention that at the beginning, and that will be posted on our website. So if there are other people in your group that were not able to attend today and you want to make sure they have this information, this will be available for them.
And I'll just conclude while we're seeing if any other questions come in. I'll just conclude by saying the only way these reports are going to get better and more useful is for us to continue getting feedback about them. So we are all ears, critical, praise. We will listen to anyone. We've gone out and done a number of clinic visits and clinic phone calls to really help a clinic understand what they're seeing in their reports. And we're more than happy to do so or to explore any particular needs that your clinic has. So I would encourage you to stay in touch. I've included our website and our email address, or you can reach out to any of us individually, and we'll be more than happy to help.
So it looks like we have not gotten any other questions. So with that, I think that we will end a few minutes early and give you all a few minutes back into your day. But we do just want to thank you all very much for attending and spending some time with us and learning more about the cost of care reports. And I just want to reiterate what Meredith said. If you have questions, we are happy to answer them. Feel free to call, an email, send a letter. And we love talking about this, so we would be happy to share more information with you.
And I'm happy from the Portland Clinic to answer any questions you have about combining reports. And I'm sure the other members of the PCC that are on the call would be happy to field questions as well.
And maybe we'll send your email address out with the follow-up.
All right. So thank you, everybody, for joining us.
Thank you.